All right, so good evening, everyone. Thank you so much for joining CVRX tonight to learn more about Barostim in patients with class 2, class 3 heart failure with reduced ejection fraction. My name is Kathy Clark Danby. I'm the medical education manager at CVRX, and we really appreciate you taking the time out of your busy schedules to join tonight's webinar. We do have a fantastic faculty lined up tonight. First up, we have Katrina Baxter. She's an advanced heart failure, heart transplant, and circulatory support nurse practitioner and the clinical transplant champion at Froedtert Hospital and the Medical College of Wisconsin. Katrina will provide an overview of Barostim therapy and the clinical data. And Jessica Griffiths, she's an advanced heart failure physician's assistant from Prisma Health Upstate in Greenville, South Carolina. Jessica will provide some insight into her practice's patient care pathways and their operational flow from patient screening to follow-up. If you have a question this evening, please type it into the Q&A and I will ask the panelists the questions after they conclude their presentations. And tonight's webinar is being recorded. So Katrina, with that, I will hand it off to you.
Thank you very much for having me. So my name is Katrina Baxter. Thank you for that introduction. I work at Froedtert in the Medical College. I have been a nurse practitioner for just over 11 years now, and nearly 10 of those I have worked specifically with this heart failure population. I'm certain that many of us listening tonight come from a variety of background when it comes to awareness or management of the Barostim device. So briefly, an overview of what our center looks like. We're located in Wauwatosa, right outside Milwaukee, Wisconsin, and we do have a comprehensive advanced heart failure program. We run a 711-bed hospital, and we do see just over 5,000 heart failure patients in our clinic. I broke that down further, and just over 2,000 of those are heart failure with reduced ejection fraction, with the greater portion of our patients being heart failure with preserved. Actually, we just did one additional transplant since I made this slide, so we're at 21 transplants for 2023. We're following 31 LVADs currently, only 3 of which are bridge to transplant, and we're following 180 post-transplant patients. We began implanting Barostim in late 2022, and we're currently managing 8 patients post-transplant. There is that we do have a large number of patients in the queue when we resolve one more internal issue, and then we look forward to expanding that population of patients. So first, I'm just going to introduce a typical patient in our clinic that we could consider for this therapy. We have a 77-year-old female. Past medical history is significant for chronic ACC-AHA stage C heart failure with reduced ejection fraction, and this patient had ischemic cardiomyopathy. Past medical history is significant for ischemic cardiomyopathy, previous myocardial infarction, PAD, ventricular tachycardia. This patient has an ICD implanted, hypertension, and diagnosis of obesity. Surgical history is significant for cholecystectomy, right femoral and external iliac artery intervention, coronary bypass in 1988, appendectomy, tubal ligation, and a diaphragm plication. This patient had a left and right heart catheterization completed in April of 2022, revealing widely patent stents, and was unchanged from her 2020 cath. She had low normal filling pressures and normal cardiac output and index. Around that same time, she had a echocardiogram, which revealed her left ventricular ejection fraction to be 20 to 24%. She did have known regional wall motion abnormalities and moderate diastolic dysfunction. This patient was on maximally tolerated guideline-directed therapy, which included the following medications. She was on spironolactone, empagliflozin, tolprol, Entresto, and vericiguat. She was presenting with functional class 3 symptoms. She was able to perform basic ADLs with minimal symptoms, but experiencing significant limitations with any type of exertional activities. She was able to walk 1/2 a block, and then she would feel short of breath and fatigued. would have difficulty climbing one flight of stairs, and was not experiencing orthopnea or PMD. She was not a candidate for CRT therapy, and her NT-proBNP trends were stable in the 415 to 908 range. So as we look at a patient like that, this was a patient on maximally tolerated guideline therapy, but still struggling with minimal daily activities and not a candidate for CRT. So what's next? Many of our heart failure patients do fall into this symptomatic category. And of course, we're always risk stratifying them for other options. Heart failure is a serious chronic condition that will get worse over time, and it can severely limit the activities that you'd be able to do and is often eventually fatal. Heart failure is a leading cause of hospitalization, and it is associated with high risk of both short-term and long-term mortality. While hospitalization is not specific inclusion criteria for Barostim, it may be a good time to evaluate if your patient is a candidate for this therapy in order to change the trajectory of their clinical course, and I'll talk more about why that might be true. With significant advancements in drug therapy for reduced ejection fraction patients, we can ask ourselves, do we even need a new device for patients with functional class 2 and 3 symptoms? Our 2022 AHA-ACC HFSA guidelines now include 4 medication classes when we're treating our heart failure with reduced ejection fraction patients, the latest addition of being the SGLT2 inhibitors. And when used in combination, there's a significant morbidity and mortality benefit. Despite the published morbidity and mortality benefit, many patients are unable to maintain target dose or all 4 guideline-directed therapies. Sometimes this is related to cost, intolerance to a medication, maybe adverse effects or an allergy, or just simply unable to reach the target dose. The dark green section on this slide shows the number of patients who've been able to reach the target dose of therapy, while the light green represents those at an intermediate dose, which leaves a large portion of heart failure population that remains under target dose or have in fact discontinued the guideline-directed therapy at 1 year. Functional class 2 to 3 patients have very debilitating symptoms that are impacting their quality of life. So what can we offer them if they are truly maxed out on tolerable pharmacotherapy? And of course, this is in addition to volume optimizing these patients. In 2 different studies, one led by Jane McLevere and another led by E.J. Stanek, they summarized that patients with symptomatic heart failure had a preference for outcomes that resulted in symptomatic improvement versus survival improvement alone. And overall, the majority of patients did prioritize treatment options that contributed to their quality of life. GDMT produces modest at best improvement when it comes to exercise capacity. So again, we're very aware of the morbidity mortality benefits of these therapies, but when it comes to exercise capacity and quality of life improvement, it has not proven to be clinically meaningful. The METEORIC heart failure study evaluated potential impact of increased myocardial contractility on multiple important measures of functional capacity on our ambulatory patients with symptomatic heart failure with reduced ejection fraction. Decreased baroreceptor signaling in what results in dysregulation of the autonomic system. The graph here shows in the upper right the specific impact of drug therapy on functional and exercise capacity. Beta blocker is the least of these as it is a beta agonist, and we understand that optimizing heart rate and rhythm has been shown to be most beneficial with regard to exercise capacity in the CRT category. CRT is a great option. However, it is only available to about 30% of the patients that then fall into that category. Specifically, we can review what the indications are. So there is a class 1 indication for CRT for patients who have reduced ejection fraction under 35%, are in sinus rhythm with a left bundle branch block and have a QRS duration of greater than 150 milliseconds and have functional class 2, 3, or ambulatory 4 symptoms on guideline-directed therapy. Or for those patients with similar qualifications without bundle branch block, they may still qualify as a class 2A recommendation. This, however, leaves 70% of the patients that fall in this category that are not eligible for CRT and are still experiencing those functional limitations despite their optimal medical therapy. So heart failure should be thought of as a systemic disease process that manifests as an extreme case of autonomic dysfunction. Once our bodies recognize that initial event to our hearts, whether it be an ischemic event or non-ischemic, it moves beyond the heart and we develop chronic activation of neurohormonal compensatory responses. When activated in the short term, these responses are intended to maintain cardiovascular homeostasis. However, over time, this leads to ventricular remodeling, progressive systolic and diastolic dysfunction, as well as abnormally reduced fluctuation in heart rate over time and increased norepinephrine activity. The autonomic dysfunction leads to worse prognosis and has been an important therapeutic target. So baroreceptors sense changes in our blood pressure and they send signals to our brain that control heart rate and vascular tone. However, when there's decreased signaling and sympathetic nervous system is activated to provide inotropic support to our failing heart by increasing stroke volume and peripheral vasoconstriction, eventually this accelerates the heart failure disease process. Increased sympathetic activity in heart failure is related to higher frequency of arrhythmia and increases mortality. Parasympathetic tone is decreased, thus reducing heart rate variability and decreasing exercise tolerance. So both of which increase heart failure symptoms. Afferent signaling to the brain via carotid sinus nerve acts to rebalance the autonomic input to the heart, and atrial baroreceptor reflexes normally contribute to cardiovascular homeostasis. This preserves blood pressure during changes in volume and posture. However, an underactive or dysregulated nervous system can present different symptoms which impact quality of life, including low energy levels, feeling sluggish, or feeling short of breath. In moderate to severe congestive heart failure, a depressed sensitivity of vagal reflexes parallels the deterioration of clinical and hemodynamic status and is significantly associated with poor survival. If we were able to impact the baroreceptor modulation of heart rate, could we rebalance the autonomic nervous system and therefore improve heart failure symptoms? I'm going to show you on the next slide a short video which will explain the mechanism of action of the Barostim device.
Barostim is an option for heart failure patients that electrically stimulates carotid baroreceptors to improve the symptoms of heart failure. The baroreceptors play a critical role in maintaining cardiovascular homeostasis by simultaneously regulating the sympathetic and parasympathetic branches of the autonomic nervous system. Afferent signals from carotid baroreceptors are constantly transmitted to the brain to interpret. The brain uses these signals to regulate heart, kidney, and vascular function via the autonomic nervous system. Patients with heart failure have decreased signaling from baroreceptors, which results in an increase in sympathetic and a decrease in parasympathetic tone. This imbalance in the autonomic nervous system leads to worsening heart failure symptoms. Barostim is delivered through a small pulse generator and an extravascular carotid sinus lead. The system works through continuous electrical stimulation of carotid baroreceptors, increasing signaling to the brain, resulting in a decrease in sympathetic and an increase in parasympathetic tone. By restoring balance in the autonomic nervous system, Barostim has been shown to significantly improve patients' exercise capacity and quality of life.
So the BeAT-HF trial was a prospective multi-center randomized trial, and this study was deliberately designed to have two phases. The first of which was a 6-month symptomatic outcome, and then the post-market phase for morbidity and mortality. Patients were randomized 1-to-1 to receive either baroreflex activation therapy plus optimal medical management or optimal medical management alone, which was the control group. And patients were followed for 6 months for the 3 primary efficacy endpoints, which evaluated 6-minute walk results, quality of life, NT-proBNP, as well as a safety endpoint. And the results of the primary efficacy endpoints around symptomatic improvement led to the FDA approval in August of 2019. It was important enough to the FDA to make this device available based on symptom relief and approve the device before the morbidity and mortality data came in. And of course, optimal medical management was defined as maximally tolerated guideline-directed therapy. Sorry. So 65% of patients treated with Barostim and guideline-directed therapy had improved NYHA class by 6 months. So 52% of these patients improved 1 class and 13% improved 2 NYHA classes. And this was a 34% difference compared to patients with optimal drug therapy alone. And for context, though we cannot compare the studies as they're different patient populations, the CRT trials noted a 20 to 30% improvement of NYHA scores at 6 months. So it can be considered comparable with regard to NYHA improvement. And the BAT did not produce hypotension in normotensive patients with heart failure. Rather, it produced a significant increase in systolic blood pressure and pulse pressure, perhaps caused by improved stroke volume due to reduced vascular resistance. So now that we can drop in the clinical evidence from the BeAT-HF study to give us the final answer to our questions, we know that Barostim does decrease sympathetic and increase parasympathetic outflow, and most importantly, it does improve heart failure symptoms. And we can take the data from the 2 randomized control studies looking at Barostim across approximately 500 patients with reduced ejection fraction and put that in context with the meta-analysis data that was shown earlier, and we see a great opportunity to help patients. You look at the GDMT studies on the left, and while there may be a significant improvement in hospitalization reduction and mortality in these patients, they only had the modest improvement with exercise capacity. And for patients with wide QRS, you do have a CRT therapy to offer to reduce their heart failure symptoms. However, now that there's Barostim for your patients that don't meet the class 1 indication for CRT, these show that Barostim in combination with GDMT could be a very important therapy for us to offer our patients. Just make sure here, okay. So again, we're looking at the clinical course of heart failure, which I described earlier. And again, there's, it is a declining trajectory. And so we're looking at a huge window of opportunity to treat patients with this device. And specifically, when we look at the indications for Barostim, it's actually very few indications. So we're looking at patients that are having NYHA functional class 2 or 3 symptoms. They're on guideline-directed therapy, maximally tolerated for at least 1 month. They have an ejection fraction under 35% and an NT-proBNP under 1600, and they're not indicated for CRT. So patients that we can consider for Barostim, ICD patient who remains limited in activity despite optimal GDMT. When we mentioned CRT non-responders, for reference, CRT non-responders are eligible for Barostim if they're not receiving adequate symptom relief with the CRT alone based on physician judgment. Barostim is an option as long as the patient meets the other indications for Barostim. Patients with an existing CRT device, they were not included in the clinicals, or they have been included in clinical studies. However, the numbers were too small to make any significant subgroup analysis at this time. But it is a population that we can expect them to study further. Patients who have challenges up titrating medications due to hypotension, patients who are hospitalized for heart failure due to recurrent and having recurrent heart failure related hospitalizations. And of course, very importantly, patients who are having difficulty performing meaningful daily activities due to heart failure symptoms. So we can look back at the patient I introduced at the beginning of the talk. And this was a patient that we typically see in clinic. She was on maximally tolerated GDMT. She was still symptomatic and not considered a candidate for CRT. She was referred for Barostim in July. And when we had our program up and running in late 2022, she then met with our vascular surgery department after having a carotid duplex completed, which showed no significant carotid disease, and bilateral ankle brachial indices were mildly reduced. And after the risks and benefits of the procedure were explained, she was implanted the following day on September 30th. Her KCCQ showed a 26-point improvement over 6-month time, with a maximal 6-minute walk test improvement of 143 meters by the time of her final titration. So in summary, despite contemporary GDMT, significant needs do remain with regards to the management of our heart failure with reduced ejection fraction patients. Exercise capacity and quality of life remain poor despite guideline-directed therapy for a large number of patients. Morbidity and heart failure mortality remain high despite GDMT, and patient tolerance and compliance with GDMT is poor. CRT, we know, is known to improve symptoms and quality of life, but it is only indicated for 30% of the class 2 and class 3 heart failure with reduced ejection fraction patients. And we now know that electrical stimulation of carotid baroreceptors increases signaling to the brain, which can help to rebalance the autonomic nervous system and improve heart failure symptoms. Barostim was an FDA approved based on the 6-month results for the BEAT-HF study, which did show significant improvements in symptomatic outcomes and decreases in NT-proBNP. So we can look at this as an opportunity.
Thank you, Katrina. And I think, Jessica, we're going to have you share your screen. And again, if you have any questions for either of our panelists tonight, please type them in the chat or the Q&A, and we will ask them at the end of the program. Jessica, you are still muted. Oh, you're still muted, Jessica. There you are.
Hello.
Yep, there you go. Great. Thanks, Katrina, and we'll hand it off to Jessica.
All right. Good evening. Yes, and thank you, Katrina, for that awesome, very thorough overview of what Barostim can do for patients. So my talk is going to be taking it kind of to the next step and figuring out how to make this happen for patients. My Barostim experience. So I'm a heart failure PA with the advanced heart failure team at Prisma Health upstate in Greenville, South Carolina. I think it's important, so you can kind of take our experience and, apply it to what your clinic and hospital setup looks like. We are not a VAD or transplant center ourselves, but our sister hospital is. So a lot of what we do is kind of combing through a ton of the community heart failure, a third of our state, and kind of picking out those diamonds in the rough for advanced therapies if eligible, or other things, other extra heart failure devices like Barostim. So I was our self-declared Barostim clinic coordinator. We started implanting just about a year ago now. And we ramped it up kind of pretty quick. We got up to about 20 implants in the first 6 months and are still going strong. So hopefully kind of a lot of the sort of takeaway pearls from my talk can help you sort of jumpstart clinics as well. So a lot of what I tried to work on in the beginning was just sort of retraining all of our providers' brains on how to incorporate this new incredible heart failure device into our normal workflow for patients. So playing off of a lot of what Katrina talked about earlier with ideal patient selection and how to get there. Other things that we worked on was how to kind of optimize the workup for Barostim in terms of making sure we had a standard process for ordering the kind of preliminary carotid ultrasound and then the blood work with the NT-proBNP to make sure that the patients were good surgical candidates, and how to kind of keep track of all this when you're trying to launch with a whole bunch of patients all at once, how to keep everything organized. And I did that with putting together some super high-tech Excel sheets that ended up being very helpful for making sure that patients didn't fall through the cracks as we kind of worked out our own kind of internal workflow. And then I also met with our clinic administration to kind of run through a lot of the things that don't necessarily jump to the forefront of your mind when you're trying to find the right patients for a new device, but also thinking about how to make Barostim Clinic a reality. A lot of the logistics in terms of making sure there was a room open to see these patients, figuring out how to schedule that, orienting all of our nurses, and working out a good schedule with CVRX for post-operative titrations, and making sure that we were billing appropriately right off the bat. So diving into kind of developing those thought process triggers. So I work through kind of screening all of the heart failure providers' clinic schedules in advance of them seeing patients that day to help try to kind of highlight and cherry pick the patients and give those providers a heads up so that the device is at the forefront of their kind of conversation with the patient and not an afterthought that you're trying to squeeze in when you've already sort of used up your whole clinic visit. So the first thing I look for when I open the chart, I just pull up the most recent echo, see if it's up to date within the year, and check the ejection fraction. And looking for less than 35. If they're over that, just moving on. Other kind of favorable qualities that I'm tuning into are all kind of based off of the last heart failure clinic note, where our documentation is kind of standardized in our clinic to include all of these elements, but looking to see if the patient has already been maximized on all kind of 4 core classes of GDMT, and hopefully titrated up to target doses as able, making sure these patients have already gotten their ICD, if not CRT, checking to see if they need CRT. And then kind of taking a step back and looking at the patient overall. Kind of my center's biggest concern when we first started this is, well, you're saying we're looking for patients on maximal 4-drug GDMT who are still symptomatic. Those are the patients who we are working up for advanced therapies. And how does this fit in? And what we kind of learned is that it fits right there perfectly. Those patients, these young patients who don't have a lot of other comorbidities and generally look like they fit the bill for transplant or LVAD, we are still going forward. We're getting the CPETs, we're getting the right heart caths, we're kind of taking all of that objective data together and deciding, is this patient sick enough for LVAD or transplant, or are they too sick? Or have we kind of hit that sweet spot, that window of opportunity where we have tried everything in kind of our conventional arsenal, and now we're looking for something a little extra to help kind of continue to temporize these patients as early as possible in their heart failure course. I'm also taking a peek at the insurance coverage for the patients. I know kind of can depend regionally and state by state, but as we kind of implanted more and more patients in the beginning, kind of just took a run at it and submitted patients, like one from every insurance plan, and just started building some experience within our area, what was going to work and what was absolutely not going to work or ever get appealed at this point in time. Just to help kind of make sure that we weren't going through a lot of effort for patients who were going to inevitably hit kind of a wall with coverage. So things that would kind of turn me off looking at the chart to thinking about Barostim for the patient is, of course, if it says patient's doing great, no complaints, then we can't improve upon perfection. So we just pat ourselves on the back for those ones. But kind of more importantly is sort of really teasing out and making sure that we're not looking at class 4 patients, and making sure that we're not looking at patients with kind of overwhelming comorbidities, who, you know, are kind of debilitated to the point that it's probably not just heart failure, and that we're not going to fix, you know, their end-stage renal on dialysis or their horrible COPD on liters and liters of oxygen around the clock. If they're non-ambulatory for whatever reason, other active malignancies, pretty much if you walk in the room and the patient looks like palliative care would be appropriate, then Barostim is not a pit stop on the way to palliative. That person has unfortunately probably just missed their window. Other things to look out for would be history of carotid abnormalities that would kind of anatomically prevent implant, especially if they've had bilateral endarterectomies, if the patient is recently positive for drugs, or if they have no insurance whatsoever. So we really drove that home with like all of our providers, trying to get everyone on the same page with which patients we're targeting. So at our center, for us, the cardiac surgeon is implanting for us, and they've actually taken on the majority of the kind of workload behind all of the insurance approvals and prior authorizations. But what we do know, what we try to do is set it up for them to make it easy. So we kind of got together with the surgeon's office and CVRx and some other successful centers near us to put together a letter of medical necessity. So this is a dot phrase. So our EMR is Epic. And so for us, we literally just type .Barostim, and it populates this letter of medical necessity that includes everything that is needed if the patient needs additional kind of supporting information for their insurance approval. And so anytime that we are referring a patient for the workup, get the carotid ultrasound and blood work, and then go to see the CV surgeon, I make sure that this is in their chart in advance to help kind of streamline the process downstream for the cardiac surgeon's office. So something that we found once we got started is that we get so excited about this new technology and this new device. We talked about it way too much. And it got, you know, kind of burdensome to address this in clinic when we're trying to move fast and we're getting farther and farther behind. So something that we looked at was how to kind of make it easier for the providers to continue to move efficiently through the clinic schedule while making sure that we kind of presented this therapeutic option to as many patients as possible. So we developed, so we have an excellent heart failure kind of clinic support staff. And so one of our nurses kind of took on a more sort of intensive role with Barostim Clinic and really loves the device and all these patients. And so what we do is when the provider meets with the patient, we kind of, float the idea out there, just, kind of see, so, you've been optimized on medical therapy, but you're telling me you still feel bad. Would you be interested in an additional procedure or device that could, likely improve your heart failure symptoms? And if the patient, jumps in, absolutely, yes, tell me more. That's when we have them check out and meet with one of our heart failure nurses who does a deep dive for all of the kind of more specific questions and really have the quality time with the patient so they feel heard and get all the information they want. So CVRx loaded our clinic up with all kinds of helpful kind of models and brochures, little videos, samples of the device, kind of everything you could ask for to give the patient a really well-rounded picture of what Barostim is and how it works, just like Katrina kind of presented for us. And we also kind of take that opportunity to set some expectations for the patient. So Barostim is a little bit different from, a basic pacemaker or defibrillator that's implanted and often never needs adjustment. So after a Barostim implant, it does require a titration. And so we wanted to be upfront with our patients and make sure that they were, kind of prepared and committed and excited to come see us a little bit more frequently to get a comprehensive titration. And then another one of the resources that CVRx gave us was this concierge service. And so every patient who we've talked to about Barostim and has been through an education session, we hand them these cards, like you can see here, to kind of get registered and connect directly with CVRx to help kind of field any additional questions that the patient may have while they're sort of making their decision. Okay, so this was my kind of first tracker that I put together to help process the patients as they're moving through the workup and getting closer to implant. So this is where if the patient was very interested in it, they want to proceed with the workup, either the providers or the education nurse adds their name to this list. We take a look at their insurance coverage and start plugging in the different pieces of the workup. And I check back on this and update it as we go. And once everything's done with the pro-BNP and the carotid ultrasound has resulted and looks fine, that's when we proceed with the referral to cardiovascular surgery. And this helped us really kind of map out our time from discussion to implant, which was, a big question up front. And so for our center, it kind of works out that the patients are usually implanted within the month or 6 weeks or so. So how do we do our implant day? Our surgeons reserve 1 day a month, and all the patients who were interested and got through the workup in time are all added onto that one date. And then we get the list of patients and set up a titration schedule. So how our Barostim clinic works, and I think it's not necessarily one size fits all, but this is what we found has worked pretty efficiently at our center. So we have dedicated every other Wednesday afternoon in our clinic, and that's our Barostim clinic time. And this is when we have the room on reserve, the nurses on reserve, and also room on the provider schedule so that we're not scrambling to work these patients in every time they need to be titrated on short notice. So our scheduler maps out all the titration visits all at once, and the patient gets the schedule up front. So we're all on the same page. So the patient gets a post-op wound check at 1 week with the cardiac surgeon, and then they come see us at 2 weeks. So the patients are usually set to 1 milliamp in the OR, and then they're sent home, given time for everything to kind of heal up and settle down, and make sure their incisions are looking nice, and then they come see us to start titration. So at our center, we're titrating every 2 weeks, and going up usually by 1 to 2 milliamps at each visit. So our first visit, we pair this device check and titration with a visit with one of the APPs to check in with the patient after implant. And oftentimes we're seeing kind of remarkable diuretic adjustments up front as the patient starts to adapt to the new device. And then the next few visits, we have the patient come back just for the device check and titration with the CVRX rep and one of our heart failure nurses. Because there isn't really a ton going on at these visits other than the device adjustments. So we kind of removed that from our provider clinic to help everything sort of move a little smoother. And then at their last titration visit, and some patients, we can end up titrating quickly within a few visits, or maybe they require a few extras, but on average, 5 visits usually gets the job done. And so we check back in with them at the end of titration, where their device settings should be stable now for the foreseeable future. And we look to see if there's anything else we can do to maximize our GDMT for the patient, if there's room now to start or go up on your ARB or ARNI. Or a lot of our patients are requesting to kind of go through cardiac rehab again now that they have a little more energy. So kind of lots of different areas to revisit. And then 3 months after the titration, where all these new, neurohormonal balances have time to just kind of settle down and even out for the patient again and get a new baseline, that's when we're looking at repeating assessments like the echo, the labs, and the 6-minute walk. After that, the patient is just seen every 6 months to check the battery life, and they should be good to go. So this, I think, is a really good little visual of what a titration schedule looks like. And so at the first several visits, we're not changing baseline GDMT. I kind of think of the Barostim titration as like a titration of ARNI or a diuretic in and of itself. So kind of focusing on that one variable and optimizing it before revisiting where they were maximized on GDMT as tolerated before. So I'm also tracking the titration schedule for our post-implant tracker. And so this is where our scheduler and I kind of get together and lay out, just map out the visits up front every 2 weeks for the patient, get them booked in clinic and kind of check these off as we go, and help kind of anticipate when the patient will need to be seen after titration for follow-up testing. And again, this is another way to help make sure that the patients are not falling through the cracks and that they're kind of progressing as planned. So it's a really good kind of overview of your whole program as you add more and more patients. So who's done and who's in active titration and new implants. So that was all I had.
Fantastic. Thank you so much, Jessica. Thanks, Katrina. And I also want to make sure I recognize the fact that Katrina just came back from the AHA Congress. So that's why she's a little bit lost her voice from coming back from the AHA Congress all weekend. So we appreciate both of our faculty tonight. Got a couple questions come in the chat, but I would definitely encourage if anybody has questions. Here's a question for the two of you. Nurse practitioners, nurses, PAs, you all spend a lot of time with your patients. What should providers be listening for when you talk to your patients about their activities of daily living? And what's some ways we can better assess those patients' functional capacity? Oh, you're on mute.
Yeah.
You're both on mute.
I know for myself, I I like to, I think as we all know, in working in different heart failure programs, patients tend to really minimize their symptoms. So aside from asking how they're feeling, I like to let them start off with a general statement of good, bad, fair, but then I get really specific and break it down. Are you doing the basic things without, feeling short of breath or tired, such as bathing, dressing, cooking? Who do you live with? When you are running errands, who's doing that for you? Are you going independently to the grocery store? When you do go to the grocery store, what size is that store? Are you using a cart to walk around and intentionally taking those breaks when you're stopping? One good measurement is sometimes, where they parked in comparison to where your clinic is. Sometimes we can be more familiar with, how many meters of a walk that might be, and ask them if they were able to do that without stopping and feeling pretty well, and how long for recovery. And I find it really important to document those specific answers because it's comparing visit to visit, those answers. One of the Barostim reps who I work closely with in our clinic, we have a patient, for example, who pretty much starts off his answer each visit with he feels terrible. But then when we break it down for him, he references very quickly 13 stairs in his home that he used to be unable to climb, where now that he's had his titrations, he's able to climb them, and he's able to remember, oh yeah, I do that now without difficulty. And then he starts to kind of feel better about where he's at. And it's not about, tweaking his perception of that, but it's our good understanding of where patients are really at functionally. And then of course, there's the more objective measurements of getting the annual CPETs or other more objective measurements of functional capacity.
Excellent. Can you guys speak to your experience managing GDMT post Barostim implant? Specifically, any changes you make in your diuretics? Do you have any experience with, and I'm going to mispronounce this, Vericiguat?
Vericiguat. Yeah, I don't know if you want Jessica to go first or myself. I know Jessica did a really good job when she outlined her titration follow-up, that they have kind of specified there when to consider decreasing their diuretics. But I think one of the very important things to remember when you are choosing to develop your Barostim program is that as we increase those titrations, it does, by regulating the autonomic nervous system, we do end up having more of that natriuresis, and patients don't require as high doses of their diuretic. So always kind of evaluating if we have an opportunity to decrease. Of course, the physical exam is the most telling for that. We check lab work, including their chemistry panels and their NT-proBNPs to add information for that. And then hopefully with most of your patients, you're able to notice that as they start to reach their optimal goal therapy of the 6 to 8 milliamplitudes, that they may actually have better tolerance to increasing or up titrating some of their GDMT, as they might have more of that blood pressure and heart rate regulation.
Yeah, and I would completely agree with everything Katrina said. And typically kind of our practice pattern is we have seen such kind of dramatic decreases in diuretics. My practice pattern has been, prior to implant, I take a peek at the patient's diuretic dose. And if they're on something relatively low, like 20 or 40 of Lasix or torsemide, I'm usually having that at implant. And then seeing how they're doing at that first titration visit. And it's remarkable how many patients who've been on this diuretic forever are now on half, and sometimes getting off of it by the end of titration. On patients on kind of like way higher diuretic doses, I do start kind of scaling back on sort of a case-by-case basis. My favorite thing of all time is having a CardioMEMS or Cordella patient then get Barostim, and you can actually kind of watch in real time how their PA pressures change and help that kind of guide things too. But we've had some really kind of huge responses, patients coming down from like 100 of torsemide twice a day down to nothing, just as needed. But they definitely kind of fall on all ends of the spectrum.
Katrina did a really good job discussing what the mechanism of action of this is. And we watched the video and we've got this nice image on screen. How do you put that in patient terms when you're talking to the patients when they come into clinic?
So I know personally, when I see heart failure patients in general, this is my own unique approach, but I always take the time when I'm establishing for the first time with that patient, if they've been seeing other providers, I kind of introduce myself to them. And I always explain that my intention is to just provide education to kind of empower them with understanding. But I take time to explain to the patients, number one, that their disease process is chronic. I think like, a lot of lay patients, they have a false security when something is controlled in thinking that they no longer have that disease process or that they don't have to worry about it. So, and we did a questionnaire long ago in our clinic, which did reveal to us that a lot of patients did not have that understanding. So I always kind of established that. And then I explained to them that when their heart is weak for any reason, that they do have kind of this chronic activation of stressful hormones in their body, which will work to kind of stress their heart out or possibly reshape it and make their heart work harder. And I explained to them that that's why when they come to the heart failure clinic, they'll see recommendations from us that might include multiple medications, which is very different than when you go to a primary care office and they're recommending one medication to control blood pressure and then maximizing that one medication before adding other ones. So I make sure that they understand our intention behind adding multiple medications and that it's because of the studies that have shown to reduce their mortality in heart failure. And a lot of times I can like see the light bulb go on for patients that they really appreciate that explanation and that they tend to improve their compliance with their medications or might be more willing or even motivated to try adding on another agent of their GDMT. So I think when I kind of reinforce that education in later visits, I can remind them that, the purpose of all of these medications is to regulate this exact system. And so it will be exciting to see what the morbidity mortality data does reveal to us over the next few months as well. But regardless, we know that symptoms are a big driver. And we also know from the studies that we shared on the slides tonight that patients really value that quality of life piece. So I think, explaining that intention, but I don't think we should ever take for granted trying to educate patients and empowering them with, in broken down terms, empowering them with understanding the pathophysiology of their disease process.
Jessica, how do you describe the therapy and sort of this rebalancing the autonomic nervous system to patients when you talk to them about it?
Yeah, so I would say, with us being in South Carolina, sometimes the health literacy can kind of leave a lot to be desired. So I break it down like really, really elementary for the patients and let them kind of build from there, if they want, if they're capable. So my spiel in a nutshell is I just kind of explain to the patients, your whole body is connected. So your heart and your kidneys and your brain are all talking to each other and all telling each other what to do. And when you've lived with heart failure for a really, really long time, all of these kind of natural communication pathways get exhausted. And one of the most important ones actually happens to be in your neck, in that we have this new heart failure device that can help kind of fix where those pathways kind of have worn out and are giving out and leading towards your heart failure symptoms like your swelling and your dizziness when you're getting up and your tiredness. And so if we can fix this one little area, it can actually have really powerful effects for the rest of your body and your heart and your kidneys. And we might be able to, kind of really make a big difference there.
Excellent. Thank you so much. So a patient walks into your office. What do you talked a little bit about this, Jessica. I'd like to hear your point of view on this as well, Katrina, just about kind of what are you looking for? Who do you see as like, if somebody is starting their Barostim program and somebody is relatively new, who are the patients that they really think they should maybe start looking at to build their program that you found that have had good results in your experience?
So I would say, we started with looking at the patients who have, had excellent trial runs at maximizing GDMT. And it's kind of interesting. I feel like as providers, like we feel so good when we get our patient on 4-drug GDMT. God forbid we make it to target doses. We, pat ourselves on the back. And then you talk to the patient, they're like, well, I still feel terrible. And I'm like, well, but you're going to live longer. The patient still feels terrible. And so it's those patients. And so for us, it was a lot of people who we were either looking at for advanced therapies, but were doing too well for referral, or patients who were kind of complaining of the same symptoms, but were just not transplant or VAD candidates for other reasons, like they were just a little too old, or they were never going to quit smoking, or their creatinine lives just a little north of 2, just some kind of major barrier where they would, do really well with something more, but their options are kind of limited. Now we have this new option. And we kind of built out from there. And now I think we're a little bit more in tune to looking at patients even a little earlier, and trying to kind of capture more of our class 2 patients. And I just asked them, I'm like, are you able to do every single thing you want to do every day? Or what's holding you up? What gets you winded or worn out before you used to be? And if there's something there that they would like to do again, I know one of our patients loved to go to car races, and he hadn't been able to do that in years, and he just really wanted to get to Talladega. Those are the patients who we are implanting and seeing really good benefit for.
Yeah, I really like how Jessica described explaining to the patients the benefit of the device, but to specify when you're building your program, we have a similar EMR system as what she has. We have Epic as well. And hopefully most systems have some type of EMR system that can extract data. So even before we are live with a new device, such as Barostim, we oftentimes will start sort of a shared patient list where we can pull certain data points that might start to help us to kind of chart review patients that we can have at the top of our mind, that discussion when they come to clinic. But I think, very importantly, again, remembering this is definitely meant to be in addition to guideline directed therapy. So I think at that visit, when you're repeating that echocardiogram after you've optimized medications and you're seeing that their ejection fraction is still suppressed below 35%, and you're evaluating their functional class symptoms. And as most of us have become comfortable with, dot phrases really help us. And so in our particular clinic, we have a dot phrase at the end with a reduced patient that automatically pulls in the 4 drug classes for GDMT. And we make sure that we're documenting that way what medication they're on, if we're going up or down on that medication. And of course, the reason that they're not on one of those classes of medications if they're not able to tolerate them. And then just below that, we also have a section for eligibility for CardioMEMS and Barostim and advanced therapies. So that's our trigger to ourselves to ask ourselves at the end of that visit if this is a patient we might want to consider for those things. And in some cases, when it's a really new device for us, in the dot phrase portion, we may even include all those inclusion criteria. So it's very easy for us to reference. And then we'll just delete that specific inclusion criteria from the note, once we've established yes or no, if that's somebody that we want to consider. So in sometimes we see a patient who's a really good candidate, and then we do directly from that visit follow up with the repeat NT-proBNP and or an echocardiogram, and then alert our heart failure nurses to follow up for us on the results of those. And if under 1600, for example, and if the ejection fraction meets criteria, then please complete that referral process to our implanters.
Excellent. Thank you both so much. We're coming up on the top of the hour, and out of respect for both of your time and our participants, I just wanted to, we can end it here. If anybody has additional questions, please reach out to your local CVRX representative. We do have some CME links that we can send you as well to learn more about this technology and learn more about the therapy. But again, thanks everyone so much, particularly our faculty, Katrina, Jessica, thank you all so much. And if you have questions, please reach out to our team and have a great night. Thanks again.
Thank you.